You're live on News at Prime. Thanks for staying with us tonight. The Special Investigations Unit has been granted 2 orders against NGOs responsible for the deaths of 144 patients during the implementation of the Life Esidimeni project. The unit says more than R500,000 will be recovered from 2 organizations and sent back to the Gauteng Department of Health. It's believed the NGOs continued to submit invoices long after the patients were removed. The SIU is also in the process of instituting civil action against the owners of 9 NGOs. The value of the pending civil litigation is in the region of R5 million. All these investigations are expected to be wrapped up by the end of November. Staying with health matters, Parliament is working hard to tighten loopholes around the National Health Insurance Bill. The chairperson of the Portfolio Committee has asked the State Attorney to give a presentation on the legal advice given to Health Minister Dr Zweli Mkhize. This is on the constitutionality of the NHI. Well, the Minister joins me in studio tonight. Thank you so much for your time, Dr Mkhize. Perhaps before we go into some of the technicalities and the responses, I wonder how you read the general reaction, be it from the public or even from some of the experts that have come out to respond to what you've tabled before the National Assembly.
Well, naturally there are different views that are coming out there, but from where we sit, we have noticed that there are those who are out there in support of the bill. There are others who have got certain objections. But by and large, the principle that we are pursuing is that of ensuring that there's universal health coverage for all South Africans, where you've got equal access to health care, which therefore means that we have to create a fund that creates a capacity to pool all the resources to be able to make the funds available so that you can purchase services to service all South Africans. Now, in this case, there are many organizations that came with us at the point when we were announcing that the bill has been tabled in Parliament, who actually were in support of the bill. You know, some of the doctors, general practitioners associations, medical association, South African Medical Association, some of the IPA forums, and then of course a number of other regulatory bodies who were all represented there, civil society, who were also out raising the issues. Actually, in fact, even the representative of some of the medical aides did say that they were supporting of the whole idea, but then they had certain reservations on various issues. I would say that by and large, the concerns were open to discussions, and so we should move on with the process and hear the views, because parliamentary process is about people expressing views and commenting on the bill.
And certainly, you know, I think that at least even from some of the conversations we've been having, the bulk of the concerns don't center around whether or not South Africa should be implementing universal health care. I think there does seem to be some kind of agreement that that's where the country needs to go. But what are some of the assumptions that you have made about the state and the quality of the healthcare system in writing the bill the way that it is now? What does it assume, or what kind of a public system would it be relying on?
Well, it is actually benchmarked on the systems that we have seen being implemented in a number of countries, whether you're talking about Japan in the East, or UK in the West, or Germany, or France, etc. This is a system whereby the first assumption is that health is a right for all the citizens, and therefore there must be equal access, and that it must be the health, it must be the disease pattern that will determine what level the person goes to, you know, in terms of additional treatment that they require. It should not be based on whether you are employed, whether you've got money, whether you are rich. It must be based on the fact that, clinically speaking, your disease needs to be taken to a particular level. So that's a major assumption here. The second one is a principle of social solidarity, wherein everybody pulls the money, but those who are healthier tend to subsidize those who are sicker, those who are younger will tend to subsidize those who are older, those who are poorer are subsidized by those who are richer, and that's a way of pulling and creating a very balanced, an equitable approach to healthcare. The third issue relates to the fact that when we do this, set this system up, it needs to be a very strong, well-administered system, which is efficient, that ensures that people do not get to suffer in accessing their health care because of inefficiencies in the system and those kinds of problems.
How much of those inefficiencies have you taken into account, and the amount of time you would need to fix them when considering this bill in its current state?
Well, there are two things which you need to take into account. The first issue is that there are lots of weaknesses in the current system that must be fixed. On the other side, there's a lot of work which needs to be put in place to be able to establish the NHI fund and the NHI processes. So you need to actually start the two, because if you are wanting to correct the health system, you need to be able to say, here is the standard, this is the goal, this is the direction we're taking, and therefore start preparing. It will take you a few years to be able to set up the whole machinery that will administer over this whole system. At the same time, you need to use that time to revamp the system, ensure that there's proper staffing, ensure that the supply of medication is secure, ensure that the facilities are improved, ensure that the quality is improved, ensure that the general culture and the ethics of running health services is in keeping with the direction that we're taking.
Sure, and the bill, although in its current form, speaks mainly to the issue of funding and not necessarily primary health care. And some of the studies that you have conducted, even the pilot phases that were implemented by the department, spoke to interventions in primary health care, and they haven't necessarily tested out any complex, any complex ways in which the funding mechanism itself would work.
What we have learned from a number of the countries is that it's not possible to implement national health insurance in one fell swoop. You're going to have to start somewhere and then improve as you move along. And therefore, we say we're going to do this in a very careful and phased manner. And therefore, what we're then saying is, there are a number of things which today we would like to see happening, but it's not possible to implement today. But then there are things that we must start doing now. So we will then use this time to solve the problems as we implement and move on. By the time we get to about 4 or 5 years, a lot of things must have changed, which means by the time we set up the structure that runs this fund, on the one side, on the other side, we must have dealt with the problems that people are complaining about.
There are concerns about the nature of the fund, even in how it's being set up. And I'll take you to a conversation I had earlier on this week with Alex van der Heever, and he is one of the governance officials at Wits University. This is what he had to say about the bill.
Apart from the other elements which we've highlighted around the establishment of what would essentially be an SOE, around the additional tax burden which would be put on South Africans, we've also seen that there is a move that seeks to essentially nationalize central hospitals in the bill. And now that creates a situation where, one, that's an erosion of provincial powers. Secondly, it also presents a unique situation where there's a fragmentation of the health system, because essentially you would have primary health care and secondary health care managed at a provincial level, and how does your referral system work? And so what we are saying is that not only is this inefficient in terms of delivering healthcare ultimately for the end user, which is the citizen, but also it might be in contravention of Schedule 4 of the Constitution, which talks about concurrent powers between provincial and national government. And so what we are asking is that Parliament must exercise its oversight role. We cannot have a situation where this bill is simply rubber stamped through Parliament. People must do their jobs, and we must see whether or not it meets constitutional muster just based entirely on this one element, and not just speaking about the other elements, which of course we are prepared to fight.
Sure. And of course, that was not Dr. Alex van der Heever. It was, in fact, Siviwe Kwarube, who is the DA Shadow Minister of Health. And, you know, she was raising the issue of constitutionality. And you're now facing a potential court challenge by the DA.
Firstly, let's accept that anybody can take the bill to court. It's their right. There's no problem with it. But what Ms. Kwarube is saying, she's got it completely wrong. You see, the issue in the Constitution is concurrency of powers on health for provinces and national government. Now, at the moment, what the bill is talking about does not stop provinces from making laws that will help them to govern their provinces on health. So there's nothing that stops them from doing that. Secondly, it does not take away any powers. What we are actually doing in the implementation process of this bill, we actually have a team that is both national and provincial officials who are looking at how we're going to work on these services between national and provincial. And we've gone through the state law advisor. We've been there. We've got four legal opinions. Each time we made some changes, we went, took it back, and so on. As we speak here today, I can tell you that there is nothing that's unconstitutional about the bill.
But does the decision-making, as far as the bill currently stands, does the decision-making not lie in the board of the health fund, which is appointed by the health minister, and they effectively are the ones who disperse the resources, which is what the provinces are concerned about, because they're saying, surely we still have to have some kind of autonomy over what we choose and what we don't choose?
There are two aspects of dealing with health. There's the issue of health policy on the one side, which is governed by National Health Act, which there's no change in that. Then on the other side, there's the issue of how do we manage the purchasing of services and the paying for services. Now, if we have an entity wherein both the national and provincial structures of government are represented, it doesn't take away the power. All we need to do is to agree, whether by regulations or by delegation of the rules of the powers to work together on that. We call that cooperative governance. But there's nothing that's stopping us from being able to do that, because we're not actually removing what's in the Constitution. If I can just take you back.
Sure. I'm going to give you a moment to complete that thought. We just have to go to a quick break. I'm in conversation with the Health Minister, Dr. Zweli Mkhize. After the break, we'll also find out about what the impact of the National Health Insurance is going to be for us as ordinary South Africans, especially when it comes to how it will affect the tax base that we'll have to be contributing towards the bill. So let's take a short break. News at Prime continues after this. You're live on News at Prime. Thanks for staying with us tonight. We're in conversation with the Health Minister, Dr. Zweli Mkhize. It's regarding the National Health Insurance Bill and what exactly it means for ordinary South Africans and how it's going to impact the lives of many of us in terms of accessing medical health care in the country. Minister, before we went to the break, we had been speaking about the kind of powers which potentially will now be are set to be contested before the Constitutional Court if the DA intends on going that far when it comes to the powers that provinces now no longer have under the NHI bill.
Yes. So the point we're making is that as the bill stands, it will have space for the provincial governments to be able to participate in the national health insurance. That the structures that will be set will actually have, if we say, for example, it's a structure that is national, it will be a structure that will have people who who represent the provinces and those who represent national. That's how it's being set now as we're trying to implement the unit that will administer over the NHI. So it actually has in it embedded the roles of the two levels of government. The mechanism of how that is done, as I said, could be delegations, could be regulations. So the heads of departments of provincial government and MECs are making input into that process. So there's no way you could actually say that national government would actually be running clinics and district directly without the participation of the provinces. So we are saying that someone misunderstood something there. The issues that they've also raised around centralization of the services is also another misunderstanding. Let me give you a sense of what happens. Now, you've got primary health care, you've got clinics, you've got district hospitals that basically serve people in a particular district, and then you've got regional hospitals where people get operated, you've got specialists and so on. Now, these services are going to be contracted to the NHI. But now let's have, when you've got people who need to get more serious interventions, tertiary hospitals, quaternary hospitals, which require more specialized services. There are not many in the country. You'll have, for example, in the Western Cape, you'll have in Gauteng, in the Free State and some in KZN. The problem with those is that you take referrals from other provinces. Now, if you allocate the funds to one province, there tends to be a distortion where one province feels that they are spending money in people who should have been funded by another province. That is how this issue arises. And therefore, going to the future, it needs to be very clear that people can be serviced in a particular hospital without living in that hospital, so that when you allocate the budget is allocated from a national central point of view to run those hospitals.
The critics see in some part the development and the establishment of this fund, particularly as a way for the health minister to be able to get, you know, his fingers in the pie, as it were, where it comes to what happens to those monies that are allocated. And, you know, part of the concern that has been raised is that our government has not been very efficient in running services, in procurement in particular. And so that trust deficit of why would the NHI fund be any different to what we're seeing play out today?
Well, firstly, let's agree that for everything that has to be done by government, there must be an ultimate signatory who is the one who must take responsibility. Whether it's president, whether it's a minister, whether it's a director general, whether it's a director, somewhere someone has to sign. So this is just an assignment of responsibility. There are checks and balances here. The definition of what qualifications are needed for the board, the advisory boards that will have to be set up, the structures have actually been built on the basis of what has been seen to work in other countries, and it's got checks and balances.
But is it a system that has been tested in South Africa? Because we currently have all of those mechanisms. You'll talk about, you know, whether it's the PFMA, under which will govern some of the procurement processes. We'll talk about the accountability mechanisms through Parliament. All of those systems have been in place, even when it comes to the appointment of board members. But yet, we still have the example of SOEs that are crumbling due to lack of financial mismanagement, really. So the question is, what is going to be put in place that's different, that can really win over the support, or convince rather the critics, and win over the support of the public, at least that part that may be skeptical? Well,
to deal with the perception of the public on the issues of corruption, there's a whole program out there, you know, the commissions of state and state capture, those kinds of processes, and the fact that you've got, you know, investigations from the Hawks. We've been talking about proclamation that allows them to go and do those investigations. Those things are there. This entity is a bit different. It's not the same as ESCOM, which has got power to take risks, to go and take money, invest it in somewhere, and borrow money, and so on. This one is Schedule 3 of the PFMA is much more limited. Like when you've got MRC or the HRC, HSRC, and so on, then what it does, it gets given a budget, and it deals with money to deal with the issues within that mandate, and it doesn't do other things. Yes, so the transparency is there, the oversight is strong, And the public can actually comment about it because they'll have a way of being able to know reports on what is going on, and there can then be intervention at any one time. The issue that we must really agree that we need to fight very strongly on is on the issue of corruption. That thing is really creating a lot of concern from all the people. So we need to make sure in this case that there's strong consequence management, proper qualification of the individual, and that we're able to take a stand each time something happens. People must be able to see that something has happened to the individual. There's consequences. So because this is a very sensitive also issue of public money and public health, it has to be very strong. When people are concerned about that, I agree. I think we must also be very, 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 strict when we come to that.
At the same time, you're also talking about money that's going to come out of an ever squeezed tax base. And there are, of course, questions around how it's going to affect the taxing of citizens. Perhaps if you can just break it down for us, how much or what percentage can people be expecting to contribute to the national health insurance?
Well, it's impossible to give you a percentage of tax as a Minister of Health. Not even the Minister of Finance can give us that so far in advance. It would be something that they put in a money bill when it is time to be able to allocate the money, and therefore we will not be able to give you that. What we can give you is just a sense of a number of things. For example, between now and the next 3 years, whatever money we need there, it's about 75 million rands to start off with to set up the entity, but then all the other money that is allocated, about 2 billion, will go into building the structures that are going to make it more viable for the NHI to be set up at various levels. So by the time we get to 2025, the estimation is that we might need to top up by about 30 billion. That issue is a projection that we have now. Going into the future, the Treasury is working on that matter, but it depends on a number of issues. What is this package of services that we are going to put into the basket of the NHI? And what is the level, what's the economic situation at that time? And all of those issues, when we pull them together, then you will have to make a determination of what the money bill should constitute. Then the Treasury will then be able to say, okay, we would have gotten money from these and these areas. Generally, the fiscus is money from taxation. So that's where it comes from.
Sure. As it stands, and very briefly, Minister, what does this bill mean for people who are on private medical health care, and what does it mean for the private medical health care industry as a whole in South Africa?
Firstly, I think we need to also be aware that there is no uniformity on people who are under medical aid. A lot of the people will pay for medical aids, but having paid their premium, they still can't get all the services that they would like from the medical aid. Some will have their medical aid exhausted because of the restrictions that there are. So, and all of those people get loaded back to the public health system. Now, what we're saying is that let's get all the contributions to come together. And some people don't even realize that the government also subsidizes medical aid, takes money from the public purse to subsidize the medical aid. We're saying that pull all those resources and let's then work together to ensure that there's equal access to everybody.
So what does it mean for somebody who's on private medical health care today and for the private healthcare industry as a whole?
Well, in terms of the medical aids, we would say the primary area for contribution will be for national health insurance for everybody. It covers everybody and everybody contributes to that. Then if people would wish to put an additional contribution, it will be on top of that, because then it would have got everyone covered. So whatever that NHI will not cover, then people can actually put up a medical aid for that. So the approach then that we will be taking is that for the private healthcare sector, there are a number of players that are in this thing. Medical aids will continue to play that role, but primary coverage for everyone will be NHI. But hospitals, private hospitals, this issue of nationalizing hospitals, I don't know where it comes from, because it's not true. The people who run the private hospitals will still keep them. Those who are running pharmacies will still have them. Practices will still have them. We'll contract them on an accreditation basis. Those who will apply to want to work under NHI, they will be asked to work under NHI. Most of the general practitioners will actually be asked, because in most of the countries, they tend to be a very the strong sector that actually works on the NHI.
There have been concerns that, especially where the private healthcare sector is concerned, that where the direction that government is going, especially under the current NHI bill, may drive some specialists out of the country.
Well, it's very difficult to talk about the issue that drives the specialists out of the country. I think people should give us space to be able to work, so that when people react and say that there's a problem, it must be on the basis that we actually see we are not able to solve the problem. I think that specialists, medical professionals, nursing professionals have been leaving the country for years. You know, if you go to Australia, there's a story that if you took away orthopods, anesthetics and surgeons, their system will collapse, because there are so many South Africans there. So the brain drain is something that keeps happening at each and every time. We're hoping that we will build the system in such a way that no one will see that as a reason for leaving the country, and we'll be sitting there in consultation to make sure that we solve the problem that professionals might be feeling, that will make them be feeling strong enough to stay and serve the system and serve their people.
All right, sure. Thank you for your time tonight. Health Minister Dr Zweli Mkhize, there you have it. That's a roundup, at least, of where things stand with the National Health Insurance Bill for now. It's a story that's really going to be staying with us for the next couple of years, especially as this legislative phase of this particular bill then gets into full gear. We'll be watching all those developments. We're going to take a short break. Mark Lewis is standing by. He'll have all the updates of what's happening and what you can expect sporting-wise coming up this weekend.